Good evening. My name is Kershaw Patel. I'm a cardiologist here at Houston Methodist Hospital. Tonight we're going to be having an excellent discussion with some of my esteemed colleagues and friends from across the country. Tonight we're going to be discussing three topics relevant to hypertension, some recent updates and recent trials that were recently published in 2021. And to go through each of those trials, we are thrilled to welcome three experts in the field of hypertension. The first that I'd like to introduce is Dr. Wanpen Vongpatanasin. She is a professor of medicine and program director in the Hypertension Fellowship Program. She is also the Norman and Audrey Kaplan Chair in Hypertension. From the Cleveland Clinic, we have Dr. Luke Laffin, who is a preventive cardiologist and co-director for the Center for Blood Pressure Disorders, and Dr. Danielle Tientcheu, who is joining me here live in the studio, who is one of our assistant professors of cardiology here at the Houston Methodist Academic Institute. So for tonight, I want to remind all of our viewers that you can interact with us, ask questions, and continue the discussion by joining through the web. If you go to pollev.com, enter DEBAKEY, and you can type your questions there, or you can text DEBAKEY to 37607 and continue on the conversation, as well as we can go into some question and answers near the end, as well as throughout this conversation. So to begin tonight, we're going to have Dr. Danielle Tientcheu discuss with us a recent trial that focuses on blood pressure targets. There's been a lot of conversation about blood pressure targets with SPRINT, but we have a more recent trial called STEP that we're looking forward to learning more about from you, and then also involving our panel of expert hypertension specialists to discuss further. So Danielle, please take it away.
Thank you so much. Good evening, everybody. It's truly a pleasure and an honor to be on this panel tonight because Dr. Vongpatanasin, I train under her at UT Southwestern, so I'm truly honored to be on the same panel as you, and just so good to see you. So today I'll be discussing the STEP trial, which was published in the New England Journal of Medicine last year. It has been well established that there's higher blood pressure is a continuous risk factor for cardiovascular disease. But for patients that are older, the optimal target is quite controversial, actually. And as of now, in 2017, the ACP recommended that for patients 60 years and above, the target be less than 150/90. However, the ACC and AHA recommend less than 130/80 for patients that are 65 and above. So like Dr. Patel mentioned earlier, the SPRINT trial was published in 2017 and had the intensive group and the standard group essentially testing a blood pressure target less than 120 for the intensive group and the blood pressure target less than 140. It was a positive study. However, the adverse events were quite significant, so there was a lot of controversy as far as whether the target should be followed. So here comes the STEP trial, which is essentially replicated. It was very similar to the SPRINT trial, and I will highlight some of the differences during this brief presentation. So it's a multi-center randomized trial in China, enroll over 8,000 patients that were aged 60 to 80. And they had two groups. One group that was the intensive group with a blood pressure target of 110 to 130. And then the standard group target was 130 to 150. The follow-up was about 3.3 years, which is very similar to SPRINT. Just to contrast, the SPRINT target were lower, so it was less than 120 and then less than 140. The inclusion criteria included the age, as mentioned earlier. They were all Chinese of Han Chinese, I guess. They did not include any minority group. And to enter the trial, you had to have either 3 blood pressure above 140 but below 190 on 3 separate visits, or currently be on a blood pressure medication. There were multiple exclusion criteria. I'm not going to go through them, but the point is that they excluded patients that had significant cardiovascular disease or had a prior stroke. So this table shows the baseline characteristic of the participant, and I'm just going to highlight a few things here. So the vast majority of patients, about 3/4, were below the age of 70, which is different than SPRINT. In SPRINT, about 25% of the patients were above the age of 75. And then only 2% of patients had renal dysfunction, so quite low. And then 6% of patients had cardiovascular disease. They did include diabetic, unlike SPRINT, and about 20% of the participants in this study were diabetic, but the A1C had to be below 8%. So this graph represents the office blood pressure measurement that was taken, and the blood pressure was measured by a trained staff, 3 readings, 1 minute apart. Unlike SPRINT, it was attended. In SPRINT, the blood pressure were unattended, so that's another difference. So as you can see, in the blue line, you have the standard treatment, and in the orange, you have the intensive treatment, and you have systolic blood pressure on the y-axis and time from randomization on the x-axis. So at the beginning of the study, all participant systolic blood pressure was around the mid-140s. Within a month, there was a drop in both groups, more so in the intensive group compared to the standard group, and that difference persisted throughout the duration of the trial. I also want to highlight that at the end of the trial, at the bottom, you can see that the mean number of medication required to achieve control in the intensive group was only 1.9, and in the standard, it was 1.5. So definitely less than what was seen in SPRINT. So this is the Kaplan-Meier curve for the primary outcome, which included stroke, ACS, acute CHF, coronary revascularization, AFib, and death from any cardiovascular cause. On the y-axis, you have the cumulative incidence of the primary outcome, and the x-axis has the time. So the inset shows you the same graph, but the scale is changed on the y-axis to illustrate the difference between both groups. On the blue line, again, you have the standard treatment, and on the orange, you have the intensive treatment, and you can see that there was an early separation of those curves, which persisted throughout the duration of the trial, and it was about a 26% reduction in the primary outcome, with a hazard ratio of 0.74 and a confidence interval that did not cross 1, and the p-value was significant. The secondary outcomes that were significant were stroke, ACS, and CHF. Unlike SPRINT, death from cardiovascular cause was not significant. Obviously, one of the main concerns with intensive blood pressure is adverse event. And not surprisingly, in this study, hypotension was significant in the intensive group compared to the standard group. But unlike SPRINT, syncope and acute kidney injury was not significant. It was similar in both groups, which is reassuring. So in conclusion, intensive blood pressure control in patient aged 60 to 80 in a Chinese relatively healthy population showed a decreased incidence in cardiovascular event. However, there was an increased risk in hypotension, but not in acute kidney injury and syncope. That's all I have, and do you have any questions so far from?
Yeah, so that's a great summary of the STEP trial, which looked at intensive blood pressure control in a different study population, specifically a Chinese population. Mm-hmm. So when we think about how to interpret these results in the context of SPRINT, do these findings confirm that we should be targeting lower blood pressure? Is there a lower limit of where we should potentially be backing off on our blood pressure control? Did these study results move you in terms of how you're deciding to manage to targets for your patients?
I think STEP confirms the fact that lower blood pressure targets decrease cardiovascular outcome, but we have to remember at what cost. So I think that SPRINT, the target might have been lower, and that was reflected in the increased incidence of adverse event. With STEP, only hypotension was significant, which is not a benign thing, especially in older patient. So my takeaway from this trial was that in the appropriate patient population, which the STEP population is definitely not representative of the average patient that we see in the office, because I mean these patients, most of them didn't have established cardiovascular disease. Most did not have renal dysfunction. Their BMI was like 25. I mean, it's a completely different patient population. So I think that if I see a patient that kind of fits that and, you know, is not taking a lot of medicine, doesn't have a lot of comorbidities, I think it's reasonable to target a lower blood pressure, but I'll probably do it in a stepwise fashion and be more cautious and monitor for adverse events before going lower than 130.
That's great. So we're hearing about a stepwise approach after the results of STEP. So I want to hear from some of our other colleagues. So Wanpen, this study population for STEP did not exclude individuals with diabetes. This was a major difference from SPRINT. How do you put these results in the context of SPRINT as well as the ACCORD blood pressure trial? What are your thoughts about blood pressure? Do these results inform us as to blood pressure targets for the subset of patients with diabetes who are older?
Yes. So first of all, I'd like to thank Dr. Patel, Kershaw, and as well as great to see Dr. Tientcheu as well. It feels like a reunion of the UT Southwestern alumni here. Yes. So I think that I would say that this trial give a little bit more reassuring. So initially, as you mentioned, the ACCORD trial did not show overall lowering of cardiovascular events. A primary outcome was not significant in intensive lowering of blood pressure. But actually, the secondary outcome, there was a significant reduction in stroke, which it's still a very important outcome. The ACCORD also have a complex design, whereas a 2x2 trial, and they have an intensive glycemic control as well as intensive blood pressure control. So it might, the intensive glycemic control have increased risks, and people will wonder if there was a sub-analysis that perhaps they don't do as well if you get both. And no one's doing that intensive glycemic control to that extent anymore. And so I think this trial where they include some diabetes patient, I think giving reassuring signals that in certain diabetic patient, lowering of blood pressure could be lead to improvement in cardiovascular outcome, particularly stroke. And also I think for this study, it at least give a lower end of systolic blood pressure of 110. The SPRINT trial didn't really they didn't have a lower end where it goes. Although I think the mean blood pressure achieved is still like right at 120-ish for intensive group. So I don't think there are too many people who have really hypotensive. But I think that it's a great signals, and I'm interested to see what meta-analysis will show in the next, I'm sure there'll be ongoing meta-analysis that include diabetes to see if it's significant this time.
That's great. So potentially these benefits of blood pressure lowering may also extend to individuals with type 2 diabetes. One of the interesting parts that Danielle brought up, Luke, is the method of how blood pressure was monitored. I know you run and co-direct a large blood pressure program at Cleveland Clinic. In terms of monitoring blood pressure for your patients, what should we be recommending to our patients? Because there was part of this study incorporated some blood pressure monitoring remotely. the results were not necessarily presented in this paper. We'll see more, hopefully coming out from such a large study like this. But how should we be counseling patients, especially in the era of targeting lower targets? What do you recommend to your patients when, especially your older patients in that age range of 60 to 80?
So I think that understanding that patients with hypertension, we really shouldn't use office blood pressures only to make clinical decisions, and we'll see follow-up data from this from the home blood pressure monitoring component to it. But I really don't put a lot of stock in office blood pressures because we know about 40% of individuals have very discordant in-office and out-of-office blood pressures. So when we're making changes to blood pressure medication regimens, I oftentimes will recommend patients take blood pressure in the morning and in the evening, about 3 to 4 times a week initially, as medications are changed and adjusted. But then other remote monitoring, digital blood pressure monitoring studies have shown once we achieve some stability in terms of those numbers, that even once a week, once every couple weeks, gives us good prognostic value in terms of where the blood pressure is. The worst thing we can have is patients checking it 3, 4, 5 times a day on end. They're going to drive themselves crazy. They're going to drive whoever's getting that blood pressure response and having to adjust it crazy. But when they do it, they have to do it in a standardized fashion. I think we all experience the patients who come in and say, yeah, I just slap my cuff on, press the button, and go from there. Well, that's not how trials do it. And so you have to be very explicit with them to sit feet flat on the floor for 5 minutes, arm resting, no coffee, or not playing around on your phone. And that's really important. And then take it in duplicate or triplicate, like most of these studies. I'll tell most of my patients to throw out that first measurement and average the next 2, because we're all going to see some variability in these measurements, but it's really basing on the averages that's going to be the biggest benefit for clinical treatment decisions long term.
That's great advice, and I think when we talk about monitoring, it's important to have good data, and multiple measurements in different settings like the office and at home can be helpful. So Danielle, just some final closing thoughts. In this trial specifically, they actually provided study drugs in different classes of agents that we would consider within the kind of first-line agents, an ARB, a calcium channel blocker, and a diuretic. Now, it was interesting, they used olmesartan,
And amlodipine.
And then hydrochlorothiazide, which will be something interesting for us as we segue into our next talk. But before that, I wanted to get your thoughts about first-line agents when we talk about blood pressure, and does this trial help inform how we should be thinking about it, or do we still feel pretty confident about diuretics, calcium channel blockers, ACE and ARBs is kind of in our armamentarium of first-line therapies?
I think the choice of first line depends on the individual patient and also their existing comorbidities. Obviously, if a patient is diabetic, I'm going to lean more towards an ARB or an ACE inhibitor. And if a patient is African American, I'll probably choose a calcium channel blocker first. So in my mind, it doesn't really change my thinking about which one I choose first. But I believe that the medication were supplied by the pharmaceutical company, so I'm not sure if that's why they chose those specific medication rather than there was some scientific reasons for it.
Great. Well, that's a great segue as we move towards our next study. Thank you, Danielle. Before we introduce the CLICK study, I want to remind our audience, you can go to pollev.com and enter DEBAKEY, or you can text DEBAKEY to 37607 and text your questions there. We'll start to incorporate some of those questions in our conversations. But now I'd like to introduce Wanpen to discuss the CLICK trial, which was a study that was published at the end of 2021. And we kind of go back to some of the questions that we think about quite often in clinic, which is which agents that we specifically should be selecting for our patients. And within classes like the diuretic class, what about chlorthalidone? We learned a lot about chlorthalidone in the ALL-HAT trial, and now this study is going to be looking at this drug in a unique patient population, a patient population with chronic kidney disease. So Wanpen, I look forward to learning from you about this study as well as getting your insights.
Thank you, Kershaw. So I would, as Kershaw had mentioned, this study effects of chlorthalidone. Before I go into the trial, I want to mention for those who are not aware. So when we talk about thiazide diuretic, traditionally it's should contain, classically it's thought to contain the benzothiazine dioxide scaffold, which is, it has 2 nitrogen and 1 sulfur heterocyclic ring, and it attached to a benzyl group. So typically, what are in thiazide diuretics? It's common, what we commonly use to hydrochlorothiazide, chlorothiazide, or benzoflumethiazide, which more often used in the UK. For the thiazide-like diuretics, this benzene ring were not present. It's the drug that it's in thiazide-like diuretics are chlorthalidone, metolazone, and indapamide, but it still has the ability to inhibit sodium chloride cotransporter and the distal tubules. So that's why it's called thiazide-like diuretics. As we know, in patients with hypertension, at least chlorthalidone has, on a milligram to milligram basis, have at least 2-fold greater effects on blood pressure. But the studies that in previous study had not examined effects on people with advanced CKD. So this is the basis of this trial, which is limited to patients with CKD4. And so people, so enroll 160 patients with CKD of stage 4 with eGFR between 15 to 30 mils per minute per 1.73 meters square BSA. And they have to have uncontrolled hypertension based on 24-hour blood pressure. I'll show the inclusion-exclusion criteria next, at least 135 or 85. And they have patient run through a placebo run-in period, and they've standardized the medication so that all the medication are a little bit more in line, the same drug. If the patient were taking ACE before, they will switch to lisinopril, or the ARBs will be changed to losartan, and all the beta blockers are changed to atenolol. Patients are not allowed to be on thiazide diuretics at the time of enrollment within the past 12 weeks. And they were randomized to chlorthalidone at the dose of 12.5, 25, and 50 milligram. And this uptitrate based on home blood pressure every 4 weeks. And it's a double-blind placebo-controlled trial. And the endpoint of the trial is ambulatory blood pressure at 12 weeks. They do have, forgot to mention that they have a 2-week washout period where they wanted to withdraw the drug and see if some of the endpoint effects are persistent. They measure home blood pressure, as I mentioned, as to decide on the uptitration of medication. And they assess the markers of target organ damage. In this case, they use the urinary albumin to creatinine ratio, and they have some markers of volume assessment, including renin-aldosterone, NT-proBNP, and body volume. And these are some of the inclusion criteria. So they have to have a grade 8 more than 18 years and the CKD4 based on the MDRD formula and hypertension. They can be on many drugs. Loop diuretics allow as long as the furosemide dose are not above 200. And the patient will be switched to, people who are on lower dose will be switched to torsemide. And they exclude some people who's going to need the dialysis in the next 3 months, or people with recent stroke or heart failure MI. And these are the baseline characteristics. It's a small trial, an average, as expected, older adults. But I think that they've done a good job to make sure that the population have quite a few African Americans. So 40% are Black patients, and majority have 70% have diabetes, 75% have diabetes, and these are the clinic blood pressure, and they found that over the period of the 12 weeks, they were to show a net difference between the two arms of 15 millimeter mercury compared to the placebo. And even after withdrawal of the drug, interestingly, the difference that attenuated but still significant. The difference is about 12 millimeter mercury. And in terms of primary endpoint, which is 24-hour blood pressure, at 12 weeks, there's just a difference of 11 millimeter mercury. And in terms of secondary endpoint, the thing that catch my eye is the lowering of urinary albumin to creatinine ratio by 50%, pretty much from like 600 to about 300 in the clothalidone group, which there's no difference in placebo. And this seems to be persisted after withdrawal of the drug, although the difference attenuated. And that definitely is a more adverse events in the clothalidone group. So the group that the clothalidone group has percent of people who had more than 25% increase in serum creatinine of almost half, 45%. And actually, those to jump ahead a little bit, they actually in the supplement, they call this as the AKI, between 25 to 50%, they call mild AKI. Greater than 50% is more severe. But that's still a debatable term because many, even among nephrologists, this easily could be from decrease in blood volume and decrease in blood pressure causing decrease in renal blood flow. And there's some other difference in the electrolyte abnormality as expected, more hypokalemia, hypomagnesemia, more hypoglycemia, and hyperuricemia, as well as dizziness, which they define as associated with a decrease in blood pressure upon standing. So those are the usual side effects which we saw in the OHAT. In terms of decrease in GFR, it's at least it's reversible so upon this discontinuation of the drug. So I think at least a lot of this is more hemodynamic driven rather than a permanent injury. So that's all I have to show. But I think that overall it's very important trial and a very clever design because it's really pretty much changed practice. Usually we don't often think about prescribing thiazide diuretics to a stage 4 CKD. So this could change the practice, although it's a short-term trial where we don't have a cardiovascular event as an outcome. So we will have to wait and see.
Well, thank you for that, Wanpen. I think that was a great explanation and summary of some of the findings from the CLIC trial. I wanted to ask you, when we see such a large reduction in systolic blood pressure, we may extrapolate those and think about what kind of CV benefits we may see. We saw about a 26% or so reduction in CV events in STEP with intensive blood pressure lowering to a target systolic blood pressure of 110 to 130. Do you think we're ready to look at chlorthalidone longer term in a patient population with CKD, because one of the concerns is the progression of CKD, what options we have for blood pressure lowering, and would we expect to see CV benefits, seeing not only a reduction in surrogate markers like systolic blood pressure, but also in urine albumin to creatinine ratio, which can have is a significant marker for risk, especially for heart failure.
Yes, so I really hope that the investigator or some other group would think about doing it further. But at the very least, what we learned from the sprint is that the initial decline in GFR, kidney function, is not associated with greater risk for cardiovascular events or progression of kidney disease. They don't improve renal outcome long term, but it doesn't really accelerate the need for renal replacement, increased risk for renal replacement therapy. But consistently, it's been shown in the sprint and the STEP trial that cardiovascular outcome is reduced. So it'll be interesting to see whether that the same outcome will happen with this clothalidone therapy in CKD4. I really hope someone would do that, but I have a feeling that with the longer term treatment, the initial difference in blood pressure might not be as well maintained, because people is going to be nervous with prescribing the therapy when the creatinine is increased. We still don't know what that means and how is that really explained in the prognosis in this population. Although in other population, like I said, in the ALLHAT or in the sprint, it does not predict the worsening of cardiovascular outcome or renal outcome.
That's great. So Luke, we now see a drug that was studied in a very robust manner in a CKD stage 4 population. What other drugs do we have available to us of all the classes for antihypertensive drugs within this class, and is clothalidone now an agent that you would feel comfortable using in this CKD stage?
I think definitely Kershaw. My standard rule of thumb before this trial was if you get down to about a GFR of 25, I wouldn't prescribe clothalidone because the natriuretic effects are not as predictable. I think this provides some good evidence that in addition to diuresis with a loop diuretic, because I think 60% of individuals were on a loop diuretic in this trial, this is going to add further blood pressure reduction, which we know is going to be important in this high-risk cardiovascular risk population. The most recent KDIGO guidelines aim for CKD, in CKD patients, systolic blood pressure of 120. So we need everything in our armamentarium to get there. Then we're restricted really in what we can use. You can't really use MRAs, or if you do, you have to be very judicious given the hyperkalemia. And then you're left with pure vasodilators. No one wants to give hydralazine 3 times a day, or alpha blockers, or central sympatholytics, your clonidine, guanfacine, etc. So I would definitely tend towards this, once a day, long acting, and going to actually help us with potassium levels in a population that was prone to hyperkalemia.
That's great. I hear Luke already talking about potassium, trying to get ready for this next part of the talk. But before we go there, I want to ask Danielle. So this click specifically looked at clothalidone. What is the role for hydrochlorothiazide of the thiazide diuretics? Is this an agent that we use, we see commonly prescribed to a lot of our patients? Should we be switching patients to potentially clothalidone who are on hydrochlorothiazide? So 2-part question, and maybe a tough one, but then amongst those patients, what should we be monitoring and how often for patients that we have on thiazide diuretics?
Yeah, so at least in my practice, if I'm initiating diuretics, I tend to pick clothalidone over hydrochlorothiazide for the reason that Wanpen mentioned earlier. It's a more potent thiazide diuretic. And in terms of patients that are already on hydrochlorothiazide, if they're doing well and their blood pressure is controlled, I usually just leave them on it. But if they're not controlled, then it's certainly an opportunity to go ahead and make the switch. As far as monitoring patient on thiazide diuretics, I typically will check just a basic metabolic panel to monitor their renal function and also their potassium. If it's a new medication and they've previously not been on it, I usually will check a BMP within 1 to 2 weeks to see where they are, and then depending on what it shows, then I will kind of decide whether further monitoring is needed and how often.
Great, and I think, you know, this patient population with chronic kidney disease, as all of us have alluded to, is a high-risk patient population with their renal dysfunction. Sometimes we see increases and decreases in certain electrolyte parameters, and so that brings us to this next discussion on the SAS trial that Luke is going to walk us through. You know, I'm sitting here looking at our panel, and it's a panel of 4 cardiologists talking about hypertension, and now we're about to start talking about dietary salt and salt substitutes. And I think this kind of brings home the importance of lifestyle changes to modify cardiovascular disease risk. And SAS was a very interesting trial, not your traditional cardiovascular outcome trial where we think about in terms of randomization and things of that nature. So I look forward to learning from Luke about this trial, because every time that I read about it, there's something new in there that I learn about, and I'm looking forward to a lively discussion. Before we go ahead and start with Luke, I want to remind everybody watching, you can enter questions at pollev.com and enter DEBAKEY, or you can text DEBAKEY to 37607. I know there's going to be a lively discussion after we introduce SAS amongst our panel as well as with the audience. So take it away, Luke. Looking forward to learning more about it.
Great, thanks, Kershaw. Really a pleasure to speak with everyone tonight and be on this panel. So what we'll do is we'll talk a little bit about SAS, published in this fall in the New England Journal of Medicine. So I guess the big thing to say is salt is truly a 4-letter word, okay, to quote the great George Bacchus. This was actually taken at a hypertension meeting. These are different kinds of salt. There's like 100 different kinds of salt. They all contain sodium. They're all bad. I've had multiple patients try and tell me, oh, the Himalayan salt is better for you. Well, maybe it is, but not for your blood pressure, okay? It's all sodium. And so in that background, we look at the salt substitute and stroke study, published, as I said, in the fall in the New England Journal of Medicine. So where are we in terms of guideline recommendations right now for sodium consumption? So the table on the top is taken directly from the American Heart Association ACC guidelines published in 2017. And it's emphasizing reduced sodium intake, as we all know, ideally less than 1,500 milligrams, but at least aim for 1,000 milligram reduction in most adults. And for example, the average American diet has about 3.5 to 4 grams of sodium a day. If we look at the European guidelines, which are in the orange at the bottom, they really recommend sodium intake is limited to no more than 2 grams per day, which is about 5 grams of salt total, but 2 grams of sodium daily. And we know the resistant hypertension guidelines published by the ACC-AHA in 2018 recommend less than 2,300. And 2,300 is really what I recommend to most patients. It's 1 level teaspoon of table salt. And so in that background, SAS was, okay? It was an open label, cluster randomized trial in 600 villages in China. Now, large number of participants, almost 21,000. They followed them for up to 5 years. The mean age was in their mid-60s, good percentage of women, about 50-50. Now, this was a very high-risk population in the sense that 73% had already had a stroke. Almost 90% had a history of hypertension. And the mean blood pressure was significantly higher than what we saw in the other 2 studies presented here, but 154 over 89. And so I pointed out, again, large number of patients enrolled in the trial, high risk. The STEP trial didn't enroll patients with history of stroke, nor did SPRINT. So this gives us some information here. The intervention in this cluster randomized control trial was participants were provided reduced sodium salt substitute free of charge as a replacement for their regular salt. And this mix was not 100% potassium chloride. It was only 25% potassium chloride and 75% sodium chloride. And they were instructed to use the salt substitute instead of regular salt for all cooking, seasoning, preservation purposes. The primary outcome was stroke, the incidence of stroke. The secondary outcome was the classic three endpoint composite MACE of a death from a vascular cause, non-fatal stroke, or non-fatal acute coronary syndrome. And then obviously was there a safety outcome as well, which was hyperkalemia, because they're giving these patients potassium supplementation. If we look at, this is a figure taken directly from the trial, we saw in everything they looked at from a cardiovascular endpoint, so stroke, major adverse cardiovascular event, and death from any cause, there was significant benefit to those individuals using the salt substitute compared to the regular salt. About a 14% reduction in the primary endpoint. The composite MACE endpoint was about a 13% reduction, and then death was about 12% reduced. Hyperkalemia, they didn't really see a difference over the course of the trial, which was almost 5 years in this setting. So, pretty significant findings here amongst this large population for a relatively easy intervention, easy in quotation marks. If we look at more granular results, comparing the salt substitute to the regular salt group, mean difference in systolic blood pressure was about 3.3 millimeters of mercury. There was a reduction in 24-hour urine sodium, which we would expect. It wasn't huge, but it was some. But there was a significant increase in urinary potassium excretion. All right, 800 milligrams up from baseline. Some of the key limitations to the study was there wasn't a measurement of serial potassium levels. So the incidence of hyperkalemia may have even been higher or undercounted. That's been mentioned by numerous commentators on the study. Some would argue that it's not necessarily a limitation in the sense that it's practical. Right? If something like this was introduced in, say, a United States setting, we wouldn't have the ability to screen for serial potassium levels. So it's pragmatic in that sense. One other limitation was there's only the one sodium preparation used. Is there a graded response? What if it was 50% sodium chloride, 50% potassium chloride? Would you see more risk reduction, or are you getting the majority just with that 25% potassium chloride? And then is this generalizable to the United States or even just other places in the world? This was a very high-risk Chinese population. Should we be limiting sodium intake in lower risk individuals that are in the United States? It's tough to translate and know how to translate that if we're thinking about it on more of a global scale. Some of the major conclusions that I draw from this trial are that large-scale salt substitution is effective at lowering cardiovascular risk. Okay, and that's the biggest take-home that I think we know from a public health perspective. And as I say there, it's a very important public health study if we're thinking about applying such paradigms in the United States or elsewhere. And then bolded at the bottom here, I think this is a really interesting principle, is the large and simple clinical trial principle. We here at Cleveland Clinic, when we're thinking about doing these cardiovascular outcome trials, at this point, background therapy for cardiovascular disease is pretty darn good. And so you need to enroll large numbers of individuals. But if you can do these large trials in a simple manner, not get everyone to throw in their pet biomarker that they need to measure, and just do a simple intervention and follow people for a longer period of time, you can get really important answers to questions, particularly when we think about implementation of these results. I think a couple of the key questions that oftentimes come up that are important to talk about, and Kershaw, maybe you'll talk about these a little bit later, but is it the sodium reduction or the potassium increase, or is it maybe both? That's really more of an academic question. when we think about this, how we implement it, it's probably a combination of both, really. We know that low potassium levels raise blood pressure, so improving people's potassium intake can help in that setting. And then is it replicable in other settings? The FDA released recent guidance saying it's voluntary guidance about reducing sodium content within the food. And, is this some more evidence and some more push to make that evidence a little bit, or that guidance a little bit less than voluntary, so we speak. So there's all kinds of questions about this, but I'll turn it over to you, Kershaw, and you can ask us any questions that you may have about it.
That's great. Thank you, Luke, for walking us through a very pragmatic clinical trial. For tonight, we have a pretty broad audience. So instead of this being more of a journal club type environment where we kind of get into the details about the design in terms of it being a cluster randomization and things like that, I want to get into some of the other more kind of clinical aspects of this. So for the first question, and please, I want to open it up to everybody now, but I'll ask it to Luke, but open it up to everybody. You mentioned you asked the question, is it the sodium, is it the potassium? My question is, we saw about a 3.5 millimeter of mercury decrease in systolic blood pressure, with a dramatic reduction in stroke. I think it was about 15 or so percent, 14, 15% reduction in stroke. What can we attribute this to? Is this a blood pressure lowering effect? Is that what we would expect with a 3 millimeter reduction in systolic blood pressure? Or do we think this was the potassium or sodium? What are your hypotheses?
I think it's probably a combination of both. I mean, that's clearly a robust response, but we do know if we look across large populations, even just a 2 millimeter of mercury increase in systolic blood pressure has the potential to increase cardiovascular risk. It may be a little bit outsized if we just look at it from a blood pressure reduction, but it's not completely out of the realm of possibility that we saw that. It's also a very high-risk population as well. And that's important to understand. These patients were, on multiple agents for blood pressure and, high percentage of strokes.
Absolutely, and I think it was interesting that the investigators made their primary outcome, if I read it correctly, their primary outcome was stroke as opposed to the composite 3-point MACE. And stroke is a very blood pressure sensitive disease. Now, when we talk about salt substitution, love to hear from everybody, but Danielle, I'll ask you first. For salt substitute, or when you're counseling patients on reduction in dietary sodium, in the United States, I imagine it's a much different intake of salts from different methods. And what I mean by that is, in the United States, there's a large proportion of individuals who eat processed foods where the salt is already enriched in the actual food product. Whereas in some different cultures and countries, geographically, there might be a different makeup in terms of the types of foods that they're eating, whether it's additive salt or the salt's already in the foods. So what are you doing with your patients in terms of counseling them about reduction in dietary sodium and salt?
Yes, that's a very good question. You're absolutely correct. In the U.S., the majority of salt we consume is actually from processed food. So typically when I counsel patient, I target the processed food because that's where the money is. So I teach them how to read labels. Dr. Wanpen, she's smiling because that's what she taught me. So it's mainly focusing on food choices, reading the labels, and then for people that enjoy cooking, then we discuss other things that they can use to season their food, Mrs. Dash, pepper, things like that, garlic, herbs, instead of using salt. But I think that this trial is very important, more on a population level. It will be very interesting to see if this can be replicated on more of a general adult population and see if we see similar results. It will probably take a longer time to see something if there's anything positive, but that might be something very interesting to see if such an easy implementation on a bigger scale can lead to improved population type outcomes.
That's great. I couldn't agree more with you in terms of educating our patients about where they're getting salt and sodium in their diets. So Wanpen, I know you take care of patients with very high levels of blood pressure and kind of all types of patients with hypertension. What type of counseling are you providing to your patients other than looking at the labels and things of that nature in terms of actual salt substitutes? Are we ready to start recommending specific formulations of salt to our patients? And did this trial help inform that?
So usually I see a variety of patients, not just hypertension, but we have some people with orthostatic hypertension as well. So I have to disclose that I don't tell people to eat less. I usually use less than 1,500 milligrams a day, but if they have some other neurogenic orthostatic hypertension, I don't recommend a strict sodium lowering, of course. I think that this trial gave us a lot of thoughts. One of the challenges I saw is that as already mentioned around the group here, that 70 to 80% of salt consumption in the U.S. is already from already processed food, not from the table. Only 25% or so from table salt. So and we usually don't cook. Fewer people are now cooking than order a takeout. So I think that's not, if we do a SAS trial here, it won't work because it's probably going to work only a minority of people who cook on a regular basis. But if we would done this, I think that it's probably going to have to be from the government or from the food that's already prepared, and it'll be interesting to see how it be done. The challenge about salt substitute is that as you already appreciate, they use 75% sodium and 25% potassium. Part of the problem is that if you give 100% potassium, it tastes really metallic, and if you want to go home and try to grab a salt substitute, you can't eat it. It tastes really bad. So, and interestingly, if you have a mix, so if you have a little bit of sodium in it and put a little bit of grading increase potassium concentration, you don't taste it as bad. So a little bit of sodium take an edge of the metallic taste. So whether the long-term acceptance of the food taste by varying this combination of sodium and potassium, would that lead to people accepting and willing to eat those form of processed food more? I think I'll be excited to see, because I think if we just putting 100% potassium in the food, no one's going to eat it, and that's going to be, it will in turn negate the potential benefit of increasing potassium. Of course, you can always counsel people to eat more fresh food and the type of DASH diet, but it's harder to do without finding a way to lower sodium in the processed food and increasing potassium in the processed food in the meantime.
That's great. Luke, did you want to share something?
I would even add, Kershaw, sorry.
Yeah.
I would even add, I agree that 100% potassium chloride tastes horrible. Sometimes what I recommend to patients, if they have to do that, then add a little bit of lemon or lime to it, squeeze it on. It tends to neutralize it a little bit. I wouldn't say it makes it taste good, but it still makes it taste better for those people that really need that essentially taste to it. That sort of tends to work from my perspective.
That's great. We're getting all types of advice here tonight about how to potentially even prepare some things and get rid of that bitter taste. And I want to open it up to everybody now as we kind of wrap up here. We heard some about interesting studies. We talked about targets of blood pressure being pushed lower and lower, and we saw that in the STEP trial. We talked about using chlorthalidone at lower and lower EGFRs in stage 4 chronic kidney disease. And now we're talking about lower amounts of sodium in salt. And so when we kind of put this together, Luke, when you're counseling your patients, you see kind of an individual who comes in with a newly diagnosed hypertension, because for a lot of patients it's been unrecognized for so long. in the current ACC/AHA guidelines, we talk about assessing individuals' risk if they're kind of at a certain blood pressure level, and then reassessing and then making decisions about future treatments. How long do you think we should be giving how long do you recommend we give individuals for lifestyle changes like salt substitution, reduction in dietary sodium, and then moving on towards therapy? And then are we starting with single therapy, 2 agents, and up titration and going from there? How much time do you give for a lifestyle before you start initiating drug therapy now?
It depends a little bit, of course, on the level of blood pressure that they're presenting with, right? As guidelines would recommend, if you're over 140 over 90 and are at any significant cardiovascular risk, you really should be starting with fixed dose combination therapy. I think we all see way too much of the 5 milligrams of lisinopril to start and then come back in 3 months, which is ridiculous. And at least the Europeans got it right in their guidelines, where everyone starts with fixed dose combination therapy. If everyone got amlodipine lisinopril or amlodipine olmesartan right off the bat, plus an indapamide or chlorthalidone, our blood pressure control rates wouldn't be in the 25% range, I think is what the most recent data is. In someone that's a little bit lower or lower risk, maybe 130s over 85 or so, I'll give them about 3 months to really make those changes in lifestyle, and picking something very salient that they can do. They may not be able to lose 50 pounds in that time, but they can monitor their salt and they can limit it to 1 level teaspoon a day, and that can be a change that they see the effect in less than a week, really.
That's great. Danielle, any closing thoughts? We learned a lot about blood pressure targets. In your practice, are you also giving patients a little bit of time to try these lifestyle modifications before initiating therapy if they're kind of in this maybe stage 1 hypertension level?
Absolutely. I agree completely with what Luke said. Depending on the level, if it's on the lower end, I definitely give people the chance to try lifestyle, and if it's higher or they're at higher risk, then I add medication from the get-go. Great.
And Wanpen, I'd love to get your kind of final thoughts after hearing about these kind of very different types of trials, if there's anything else that you'd like to add.
Yes, so I think that since with the pandemic, it's still ongoing and probably going to be for a while, I think that we're going to see more and more the use of home blood pressure monitoring, particularly when you can link with the app, like in the STEP trial. That's what they do to help engage both patient and physician get the output as well. And I think that's going to be a way to go to actually increase the patient engagement and also feed the real data to physician that they can trust better, because it comes through a portal where instead of writing in a piece of paper and trying to average in your head. And I think that I hope that the dissemination for ACC and AHA, and with the recent increasing introduction of the home blood pressure, I have to give a plug, since I'm a member of validatebp.org, is to should advise our patient and actually a clinician to go to validatebp.org, which is the AMA/AHA website that inform the consumer on which monitors are reliable. It has the home blood pressure and the office, and also the one that you can find at the pharmacy kiosks. So you should look into that.
That's great. I think we could have a whole nother conversation about home monitoring of blood pressure, reducing therapeutic inertia, so we can get away from this kind of low dose of a single agent for patients who have very high levels of blood pressure. I want to thank you, Wanpen, Luke, and Danielle here in the studio. This has been a great conversation. I hope we can continue this in the future. And for all those who have been watching, we appreciate your time and thank you so much. Thank you, everybody. Have a good night.
Thank you. Good night.